Okay, this is Chapter 7 for the EKG text, and this chapter deals with the QRS complexes. So what were the first three steps that we used in evaluating an EKG? First step, we looked at heart rate. Second step, we checked to see the regularity. Third step, we assessed the P waves. And now we're going to move to the fourth step, which is evaluating the QRS complex. So what does the QRS complex tell us? It lets us know if and how well the impulses are coming through the ventricles, or if they're originating or starting in the ventricles. It's usually normal if the rhythm is initiated in the SA node, in the atria, or in the AV junction. If it's in any of those other spots, it's typically an abnormal QRS complex. If you have any delays or interruptions in that conduction, it can be very serious or maybe even be life-threatening conditions for your patients. So the QRS complex is usually upright. It's larger than your P waves because the ventricles depolarize using a lot more muscle mass. So it's a larger section of muscle that is being used to depolarize. And the ventricles depolarize so fast that it usually makes that QRS look very thin, thinner than other parts of your EKG. So it looks like it's going to be skinnier. If the Q wave is not present, then you're going to have to measure from the next spot that you can identify, and usually that's going to be your R wave. The J point is the junction where the QRS meets with the ST segment. It's a flat line that connects the QRS complex and the T wave. The end of your S wave is going to transition you into the ST segment, and that point at the baseline where the QRS comes back down to baseline is called the junction or the J point. So you'll need to be familiar with that terminology. The QRS is positive deflections, those are R waves, and negative deflections that are the Q and the S waves. So that's where they go up and down. You're not always going to see all three of those waves. If you do not have an R wave, you refer to it as a QS complex. If you do not have a Q wave, it's going to be an RS complex. So some variations you're going to see in these. If you have a higher than normal amplitude, that means that it's found in the precordial leads. So if you're using the precordial leads, it's going to look very tall. It also, if it's very tall, means that there is ventricular hypertrophy. And if you remember from medical terminology, hyper means more than normal, trophy is development. So that muscle will look big, but it's not usually toned. It's kind of flabby looking, so it won't work effectively. So you would think more heart muscle would be a good thing, but if it's hypertrophy, it's not very refined, effective muscle. If you have a positive impulse directly following your R wave, that's an R prime. If you have two of those, it's double R prime. If you have a negative impulse immediately following your S wave, that's an S prime. And if you have two of those, it's a double S prime. So you want to be sure when you're looking at your QRS that you're looking at the location, what they look like, and the deflections. Is it going up or is it going down? When you start to measure your QRS, you're going to start at the very first spot where it starts to leave the baseline. And it's going to end where it comes back to the baseline. So that's the J point. The ending point is the last wave of your complex where it begins to level out or get flat. It's either at, above, or below your baseline, and we call that the J point. So finding exactly where it ends sometimes can be difficult because it may not be a very clear spot on your tracing. So you want to be sure when you're measuring you're using the entire S wave, but you should not go over into your ST or the T wave. So the normal duration of your QRS complex should be 0.06 to 0.10 seconds. So 6/100ths to 1/10 of a second. So it's helpful if you look for the end of your QRS complex in as many leads as possible, because you know that gives you different views. And sometimes it can be really hard to see where it may lead into another. So determining where your QRS ends can be difficult, especially if you've got depressions or elevations of your ST segment. Look for a small notch, a slope, or another movement in that line that suggests that there's an alteration of your electrical flow. So use this algorithm to help you determine what types of QRS complexes that you might be dealing with. So you can see the normal, it's narrow with the correct amplitude. You may have chaotic or absent, and you're just not going to see it at all, or it's going to look very bizarre. And then your sections of your abnormals, you can have tall, low voltage, you can have delta waves, you can have notched, or you can have wide or bizarre looking. So you need to be able to evaluate them to determine are they normal, abnormal, or maybe even absent. So with a normal QRS, it should be upright and narrow if it's coming from a site above the ventricles, if that's where your rhythm is initiated. If it progresses normally through the bundle of his, down through the right and left bundle branches, and through the Purkinje network, it should be normal. And if it has normal depolarization of your ventricles, it should be a normal appearing QRS. That's usually sinus rhythm and even some sinus dysrhythmias that arise above your ventricles. That means there's no delay of conduction and everything moves through as expected. Then you start having your abnormal QRSs. That happens when it is an abnormal depolarization of the ventricles. It could be because the pacemaker can be the SA node or an ectopic pacemaker in the atria, the AV junction, the bundle branches, the Purkinje network, or the ventricular myocardium. If it starts from any of those spots, it could be an abnormal QRS. The shape may look funny. It may be really narrow. It could be very tall, may be low amplitude, not move off of that line very much, or it could be wide, bizarre looking, or look slurry, or maybe even notched. A lot of different things can cause an abnormal QRS. Ventricular hypertrophy, and we just talked about what hypertrophy is. So if the ventricles are not good effective cardiac muscle, it'll give you an abnormal QRS. An aberrant ventricular conduction is pretty common, and it will produce a wide QRS complex. Ventricular pre-excitation is a shorter than normal PR. If you have a tall QRS, it's usually caused by ventricular hypertrophy, and it can be one or both of the ventricles. It can be an abnormal pacemaker, or it could be an aberrantly conducted beat. It's just not being conducted. Aberrant means departing from the expected standard, so it's anything unexpected. You can have low voltage QRSs. If you have an obese patient, their EKGs may look like this. Their QRSs may be very low voltage, kind of spread out. If they have hyperthyroid patients, that can cause that. Or even a pleural effusion, and that's a respiratory problem that you need to look up and know what they look like. You may end up with a wide or a bizarre looking QRS, and that's usually from a conduction problem in the ventricles. You have a right or a left bundle branch block that will give you a wide QRS. There's your aberrant conduction. Usually the electrical impulse reaches the bundle branch when it's still refractory after it's conducted a previous electrical impulse. It gives you an early impulse going down the unaffected bundle branch, and then the other bundle branch gets stimulated. So that's going to make your QRS look wider than normal. So spend some time looking at this and reading about this in your book. Ventricular pre-excitation. Usually it has an abnormal slurry looking at the onset, and you can kind of see that in that diagram. We refer to that as the delta wave. So go back and read about your delta wave. If your patient has a pacemaker, an implanted pacemaker, that's usually going to make a little bizarre look to their EKG, and it's usually going to be before each QRS you're going to have a pacer spike. And that's a very quick way that you can tell if your patient has an implanted pacemaker. You'll see that spike before their QRS. If your impulse is originating from ventricular tissue, you get ventricular dysrhythmias. They are typically going to be wide. They may be bizarre looking, or you may have a T wave that's going in opposite direction of your R waves. Sometimes the ventricles will fire before your SA node can, so that can be a ventricular issue causing your EKG abnormalities. Usually it's going to be with a sustained escaped rhythm having a rate of 20 to 40 beats per minute, or maybe even slower. So if you see your patient's heart rate is very slow, that is probably going to be because they're having ventricular impulse initiation. So idioventricular rhythms arise from the ventricles when stimulated from the SA node. The AV junction fails to reach the ventricles, and the rate falls to less than that of the ventricles. So your atria are going to contract faster than your ventricles are. Ventricular tachycardia. Tachy means fast, remember? So you're going to really rapid depolarization of the ventricles that will override your SA node. So that's tachycardia that comes from your ventricles. You're going to have 3 or more early ventricular beats right in a row, and you may see these in bursts of 6 to 10 complexes. And this heart rate is going to be between 100 and 250 beats per minute. So ventricular tachycardia is going to be 150 or 100 to 250 beats per minute, where your idioventricular rhythm could be very slow, 20 to 40 beats per minute. If your ventricular waveforms with tachycardia, you're going to see more than one ventricular focus in those. It looks like a series of QRS complexes that rotate around your baseline, up and downward deflections, and it looks spindle-like. So you can see that looks, it doesn't look like an EKG, but you can see that it just looks like a spindle kind of spinning back and forth. If you have a wide QRS, that can be an AV heart block. Something is preventing the impulse from traveling through the atria and the ventricles normally. So the location of the ventricular escape pacemaker site determines what your QRS looks like. So a wide, large, bizarre-looking QRS complex can indicate that your ventricles are being paced by ventricular focus. If you have a chaotic, wavy-looking line, this is VFib, ventricular fibrillation. And remember, we've said in just about every chapter, this is a life-threatening dysrhythmia. And the way to correct this is with defibrillation. So you're going to have to shock someone's heart to get it out of this chaotic-looking rhythm. And you have to do that very promptly. So ventricular fibrillation causes the heart muscle to just quiver. It's not beating effectively. It won't contract effectively. And if it can't contract, it's not going to pump your blood. So it just kind of lays there and quivers back and forth, and it's not effectively pumping. Then you have a flat line, and you can probably imagine what that is. That is asystole. There is an absence of the contraction of the heart. So you're not going to see those deflections because the heart's not actually working. So there's no activity in those ventricles, and the cardiac output stops. So look at this EKG and tell me about the rate, the rhythm, and the type of atrial waveform that you see. You may want to pause this while you're analyzing it. This one is a normal QRS complex at 0.08 seconds in duration. Now take a look at this one. This one is an RS complex with 0.08 seconds in duration. Now take a look at this one. This one is a normal QRS complex at 0.08 seconds. It has some early beats and a wide bizarre QRS complex, and it's at 0.24 seconds in duration. Now this one. This one has a wide bizarre QRS complex at 0.16 seconds duration. Now this one. This one is totally chaotic. There's no QRS complex in this. So, to summarize, the QRS complex is the next step in analyzing your EKGs. The QRS starts where the first wave starts to move away from the baseline, and where it starts to come back is where it ends. The QRS is larger than the P wave because there's more muscle involved, and the ventricular depolarization uses a larger area of muscle, so it takes longer. The amplitude is 5 to 30 milliliters, and the amplitude is 5 to 30 millimeters, and the duration is 6/100 to 1/10 of a second. The Q wave is your first negative deflection from the baseline after your P wave. The R wave is your first positive deflection following the Q, or the P wave if you don't have a Q. The S wave is the first negative deflection that extends below the baseline. Normal sinus rhythm and dysrhythmias that arise from above the ventricles usually have a normal QRS complex. Abnormal QRSs are produced by abnormal depolarization of your ventricles. Duration of an abnormal QRS is greater than 0.10 seconds. The shape varies from almost normal to wide and bizarre or slurred and notched. Tall QRSs are usually caused by hypertrophy of one or both of the ventricles, or by an abnormal pacemaker or aberrantly conducted beats. Low voltage or abnormally small QRSs are usually in obese patients, hyperthyroid patients, and people with pleural effusion. A wide QRS, wide or bizarre QRS complex of supraventricular origin usually result in intraventricular conduction defect, and it's usually a right or left bundle branch block. The wide QRSs may be seen in aberrant conduction, ventricular pre-excitation, and with a cardiac pacemaker. Your greater than 0.12 seconds in duration are usually seen with ventricular dysrhythmias. And with torsadas de pointes, the shape of the ventricular waveform changes, and that starts to be spindle looking on your EKG. Third degree AV heart block is another dysrhythmia that can show you an abnormal QRS. And ventricular fibrillation, or VFib, appears as a chaotic wavy line with no discernible waveforms.